welcome to our Audiology Online recording. We're going to be going through a case study today. Our learning objective is that through this presentation, the audience will learn more about the long-term management of pediatric patients.
So our patient is a 6-month-old baby girl named Amanda who has one older sister who is 7. Their dad is a full-time mechanic, and then while the dad is at work, the grandmother is the caretaker who's kind of watching them. Both the grandma and the dad report the patient as being very shy as a baby, and both her and her sister are very shy.
Okay, so first we sent a case history questionnaire out to the family. They did have some concern about her hearing due to her ear shape, and she did not pass her newborn hearing screening. There is a family history of hearing loss, and we know that she is seeing an SLP and several doctors, but we didn't get a lot from this questionnaire. So it's just important to keep in mind that parents will answer what they know, and they might not know the questions that you're really asking them. So in-person follow-up is always important.
Mm-hmm. So at the in-person case history, we did notice that she had an abnormal ear shape on both sides. The family history, when asked about that, we found out that the father actually had congenital conductive hearing loss, and he had had articulation difficulties all his life, and so that was just something important to know about, because at first in the case history, like questionnaire, it just said, yep, the dad had a hearing loss, and not what kind, any difficulties, that kind of stuff. So that was a very important follow-up question that we thought. So like we said, she had been seeing an SLP since she was born, and then the SLP actually comes into their home and then works with both Amanda and the grandmother, just so that the grandma can kind of see what they're working on. And then when she came in, she also had come in with the diagnosis of Treacher-Collins from their pediatrician. And she also goes in for well baby checks at like the ENT, just, like with the fluid in their ears, and for possibility of PE tubes in the future, but just for checkups and to monitor that kind of thing.
Okay, so once we found out her diagnosis, and after talking with the parents, we had her come in for a full diagnostic assessment. At this appointment, we found that she did have atresia as well as abnormal ear shape, so her ear canal was missing, not only the outer ear. So we could not perform otoscopy, any admittance measures like tympanometry or acoustic reflexes, and we could not test OAEs, which are all pretty important assessments for children, so we kind of had to make do with our other assessments. We did test her using an auditory brainstem response, using bone conduction, which revealed thresholds in the moderate range. Then to kind of bolster those results, we went into the booth and did visual reinforcement audiometry with her. She was a good tester. She responded when she should have. She was a good baby. And VRA revealed moderate sloping to moderately severe mixed hearing loss. And for that testing, we used the bone oscillator and circumaural headphones so that we could sort of get an idea of her hearing without using inserts because of the atresia.
Okay, so our treatment plan that we kind of came up with was we referred to the primary care and like ENT just for continued monitoring of the middle ear functions and like fluid and stuff in the middle ear. Also for imaging of the middle and inner ear, we suggested to be fit with bilateral softband bone conduction hearing aids, which you can't really see by the picture, maybe if we move that. So that is kind of what we're talking about, just so it sits behind, so there still is that option of amplification. It's just not the typical hearing aids that we probably normally think of. And then the birth to 3 services, it's kind of an accumulation of providers, so like PT, OT, that come to the home and work again with, like the grandmother, the father, that kind of thing. So it's very convenient, and it's at no cost to them. And so to look into services such as that to kind of help with her overall development. We suggest that the dad start to look into the school districts and get in contact with the school just to kind of figure out, like the possibility of a 504 or even an IEP, and just to also suggests an amplification system for her in the school when she becomes of that age. And then also did we would suggest like monitoring of the hearing status, so like annual checkups and stuff with the audiologist, and also there was one more. Oh, and then just to continue with the SLP in her school.
So we did go over the whole course of treatment with her parents at this time. So this included talking to the craniofacial team and the ENT, sort of telling the parents what would happen roughly when. So that she might need cleft lip or palate surgeries, she might need microtia or atresia surgeries, and sort of when those would happen just over the course of her life as determined by the craniofacial team and the ENT. Okay, so that was all happening when Amanda was 6 months old. When she was about 10, we had another sort of significant finding with her. So she did continue wearing her bilateral bone conduction devices on a soft band. Her parents decided to continue with the soft band rather than getting the surgery because they wanted to wait on that. Amanda, though, wanted to get the surgery because she was feeling embarrassed about her devices and the soft band every day. So she was having some sort of social emotional disturbances about her diagnoses and her devices. After interacting with her, we did become concerned about depression and anxiety and just sort of her mental health overall. So we did want to sort of update our treatment plan after finding out this. We did also talk to the school. They had some concerns that she was skipping class and not sort of interacting with her peers very much. So we also took that into account in our updated treatment plan.
So for our updated treatment plan, so we kind of went through the counseling with both Amanda individually and with her family. So with talking to Amanda, we really kind of emphasized like taking ownership in her own devices and making sure that she is wearing her soft band hearing device, and if she had an FM system at this point, that would also be utilized. And then we also, this kind of is talked about a little bit later, but with the self-advocacy, making sure that she is trying to get involved in school, especially with, like school is hard for anyone, but especially if you have, like the craniofacial abnormalities and, like a very visible hearing device that probably is not easy for her. So just talking about, there are camps and support groups of, kids with hearing loss, and I'm sure there are more kids with hearing loss in the schools, and so looking into that and to try and get her more involved with peers in the school, so having her pick out an activity that, like meets once a month or like some kind of club of some sort in the school, just to kind of help her get talking to people and that kind of stuff. And then with the family, we also talked about like the camps and the support groups of kids with hearing loss, because that's just more resources for them to have. And then also helping that they kind of reinforce the self-advocacy. Like, it's one thing for us to tell her, but it's another if she actually does it. And so just to have them kind of monitor to make sure that she is going through with that. The thing that we really wanted to emphasize was the book Wonder. That actually focuses on a child with craniofacial abnormalities and wears actually the bone conduction hearing device that Amanda is wearing at this point. And so we think it kind of goes through the motions of having, there is an older sibling involved. And so it's just kind of a good conversation to see how the family interacts together. And there are certain, like a bunch of book group questions and stuff that we have recommended that they kind of just sit down and talk about, maybe like one chapter a week or that kind of thing. So just, it's good even to have the audiologists check in with it too, just to make sure, once again, the family is communicating and they are going through with that together. And then again, with the self-advocacy, possibly doing a hearing aid show and tell for Amanda, just to make her not only more comfortable with her devices, but having kind of lowering the stigma of wearing her devices, and so that way like her peers actually know what it is she's wearing, what it's doing, that kind of thing. And she could either do that in a big group setting, like in front of the entire classroom, or if she's more comfortable, maybe just in a small group with a couple of peers. Um, Teaching communication strategies, like that kind of just making sure she's in the front of the classroom, or being assertive in the sense that if she doesn't hear something, speak up and ask the teacher to repeat it, or ask peers next to her to help her with the directions and that kind of stuff. Speaking up for herself also. And so I think just getting her involved in a lot more will also give her more comfort to speak up for herself, and more comfort talking in front of people with like the craniofacial and the hearing devices. There are so many other things going on. Of course, we're just looking at the hearing devices. There's so many things going on aside from that. And so just to make sure that we as audiologists are communicating with the school, with the family, with all the primary care, that kind of thing. So it's just a very interdisciplinary group effort. Some referrals with the mental health that she has kind of showcased concerns about. We are recommending that she sees someone for a psychological evaluation or counseling for depression and anxiety. So like either the school psychologist or someone outside psychologist, social work, that kind of thing. And then also just to follow up with an educational audiologist, because they're the ones who are going to be seeing her in the school setting most, rather than us in the clinical setting. And yeah.
So overall, thank you for listening to our presentation. We hope that you learned a lot about the long-term management of kids and how it really does take a village to get all of their concerns met.
Thank you.